Hello, everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Charles Hawley, NADO's Director of Projects. Charles, the stage is...
Good morning, good afternoon, everyone. Thank you for joining us here for the session Governance, Linkage, and Sharing of Health Data. One is not enough. I wanted to say thank you to our sponsor, Civic, the Center for Improving Value in Healthcare, and just read a brief statement before I'll introduce your moderator, Leanne, Candura, and turn the show over to her. So let me put the statement here on the screen. So the Center for Improving Value in Healthcare, or Civic, is an independent nonprofit that equips partners and communities in Colorado and across the nation with resources, services, and unbiased data needed to improve health and healthcare. As the designated administrator of Colorado's all-payer claims database on behalf of the state's Medicaid department, Civic oversees the collection of healthcare claims from Colorado's public and private healthcare insurers and uses that information to promote price transparency, inform policy, advance health equity, conduct research, and much more. They are objective, solution-oriented, and maintain the highest integrity in the work we do. Last year, Civic celebrated the 10-year anniversary of the Colorado APCD, and they are proud of how they've enhanced the quality and completeness of the data, their overall analytic capabilities, and breadth and depth of the data they provide publicly and on a non-public basis. This session is particularly exciting to Civic because they are currently working on expanding their data governance structures and linking to external data sources, including HIEs, registries, and other APCDs. They value the connection with peers that this conference provides and look forward to learning more from the presenters in this panel. So without further ado, as I mentioned, let me bring on stage Leanne Candura with HSRI, who will be moderating this session, and I'll turn it over to her. Thank you, Leanne.
Thank you, Charles. Hello and welcome to today's session, Governance, Linkage, and Sharing of Health Data. One is not enough. My name is Leanne Candura, and I'm Vice President at HSRI and Director of our Population Health Team. I'm also a proud NADO board member serving in my second term, and I'm thrilled to be moderating today's session. A special thank you to Lori Savoy of the Utah Department of Health and Human Services, who organized today's session. HSRI is a nonprofit, mission-driven institute that provides services to improve the systems that improve lives. Our population health team builds data systems to collect, analyze, and report health data to improve the quality of health information available for research, policy, and practice. We partner with clients to find ways to enable the creation of innovative integrated data products while reducing overall costs. I'm excited for today's session to learn more about how our incredible presenters are supporting the linking and sharing of health data to improve health. Here at HSRI, we are focused on person-driven solutions, and we know that data about a person is not in one system. Bringing together a variety of data systems helps us to provide both important contextual information and helps us to better understand and improve a person's health and well-being. But also, we need to care about the data and an individual's privacy within and across these systems. So I'm excited to kick today's session off with Graham Krabach and Jennifer Braun of the Washington State Department of Health, who are presenting on implementing a master person index for Washington State's notifiable conditions database. Thank you.
Hello, and welcome to this presentation on implementing a master person index for Washington State's notifiable condition database. My name is Graham Krabach, and I'm an epidemiologist and informatician with the Washington State Department of Health. This presentation covers work that my colleagues and I completed at DOH over the last few years. We'll start with a brief overview. So we will begin by going over DOH's current software for person matching, and then discuss the reasons for implementing an MPI, as well as the project goals for our notifiable condition database. I'll then move on to methods, and for results, we will compare person matching and performance time between MPI and the current software. I'll then finish with a discussion of the strengths and limitations of this work. The majority of notifiable disease records that Washington State analyzes are created by a lab report. This could be either an electronic laboratory reporting, or ELR message, or a manually received message. ELR messages are received in HL7 format from our submitters, and some labs send fax or emails with PDF or Excel files attached that are then hand entered one by one or bulk uploaded to our databases by CSV. And these are what we're calling manual labs. All labs for most of Washington's state and federally notifiable conditions land in the Washington Disease Reporting System. And this is an implementation of Conduent's Maven software. I'll be calling it WDRS in this presentation. And just to note, we wanted to paint a full picture of what we're doing with our MPI implementation. So I will be describing the architecture for all lab messages, ELR or manual, in the background. And then once we move on to methods and results, we'll be focusing in on just ELR messages. So this shows our current architecture without MPI's implementation. On top, you can see the data pipeline for ELR messages that begin as an HL7 and are parsed to XML before passing through exact person matching type 1. And I'll get into the details of what that entails on the next slide. ELRs are then passed through report standardization before going to WDRS. CSV data files, or those manual labs, go through a more conservative person matching, which we're calling type 2, and have fewer steps on their way to WDRS. All incoming lab reports end up passing through person and event deduplication software at WDRS. These are the pre-MPI person matching processes. So on the top, we have type 1, and it's important to note that all of these are exact matches. Type 1 is less conservative as it allows for the use of either date of birth or social security number, and it also allows for alternative names to be used in the matching process. CSVs go through a more conservative process that requires social security number. Both ELR and CSV records are evaluated for inclusion in the manual deduplication queues within Maven using the same algorithms that use first name, last name, date of birth, social security number, and gender. So what is a master person index, or MPI? Utah defines it as a secure identity resolution, data integration, and information sharing hub. Multiple state agencies in Washington that work in health and human services are collaborating to choose and implement an MPI. And we've gone with the vendor Verado. Verado records person-level data in a Washington-specific tenant that is shared across the agencies. Verado also conducts probabilistic record linkages to identify whether incoming data relates to a party that's already known. The goals for our WDRS MPI project, which is just one of many within the agency's coalition, include firstly, decreasing the number of records that pass through manual deduplication. Next, we want to promote more accurate and up-to-date demographic and contact information, which is relevant for case investigations and contact tracing. And third, we hope to connect identities between surveillance systems, for example, between WDRS and our immunizations database. This is a deeper dive into the WDRS MPI architecture for ELR messages. These data elements are those that we send to Verado for use in their proprietary probabilistic record linkage software. And you can see that this is an expanded list, which now includes phone, multiple address fields, and gender. If the person matching software identifies a match, it will pull the WDRS ID from Verado's database. If no match is identified, it will ping WDRS using an API call and grab a new ID that hasn't yet been used. All records get an MPI-specific link ID, which is then paired with the WDRS ID and stored together in what we call the link database. Multiple labs pertaining to the same individual are often received in quick succession. An MPI is able to create a new party and assign all related labs to it immediately. So here we have those pipelines, and we've removed the exact person matching types 1 and 2 and replaced them with MPI for person matching. As you can see, records are still passed along to WDRS for evaluation as to whether they should be sent to manual review, and our goal is to reduce the number that's sent to this manual deduplication. To compare our MPI implementation to existing software, we conducted around a week of parallel testing, wherein we routed all incoming ELR messages to 2 nearly identical environments. Production used exact person matching, and test used MPI for person matching. This testing was done in late May, and we excluded individuals who had differing demographic information between the environments. For data analysis, we looked at the count and percent of ELR messages that matched to known individuals in production, test, or both. We were looking at the total overall and then stratified our results by health condition. Our test of whether the environments identified the same matches was a McNemar's test, and we also looked at whether processing was the same between both environments using a Mann-Whitney U test. Over the period of study in May, we received around 6,600 ELR records, and this graph shows their processing in each environment over time, with the test environment slightly delayed behind production. After excluding those records that didn't pass through both environments during the period of study, we're left with a sample of around 6,400 ELR messages. And when comparing those that matched to existing parties and test to those that matched in production, we found that 66% matched in either or both, with the majority, 55% of all records, matching in both environments. The test environment alone matched 397, and production alone 315, which is a difference of 82. This figure shows the same data presented on the previous slide. This is a table stratifying our results by health condition of the incoming record, and we've limited this to conditions that received greater than 100 ELR records during parallel testing. 4 conditions had statistically different numbers of records matched by the 2 environments. Hepatitis A, B, and other hepatitis-related labs all had more match in the test environment by MPI, and blood lead had more match in the production environment using our older exact matching. There was no statistically significant difference for COVID, hepatitis C, or tuberculosis. In this slide, we see the median and interquartile ranges for processing time in both environments. The median time for records to flow through the test environment was 15 minutes longer than those flowing through production, which was statistically significant. We wanted to outline some limitations of our analyses. We identified several software bugs in the test environment during and after parallel testing, which may have impacted person matching and processing times. The test environment is allocated less processing power than production, which may have artificially inflated the MPI processing time. We wanted to also highlight limitations of the MPI solution overall. The proprietary nature of our linkage algorithms meant that it's not easy to change them over time, and it's also not clear or transparent why a match occurred or did not occur. Washington has only onboarded 2 data systems into our MPI so far, which may impact matching performance. And our MPI solution did not come with a never match option right out of the box. This would have allowed users to specify parties that should never be matched to, and we had to custom build this on our own, which took significant time. The MPI person matching identified matches for a higher proportion of lab records than our current software. And we learned in parallel testing that MPI's ability to assign a newly created party ID, or WDRS ID, to all of that individual's inbound records is an advantage over our older system. We estimate that MPI could reduce the number of newly created records queued for manual deduplication by around 14 a day. And there's the possibility that onboarding additional databases in the future will improve our matching performance. Thank you all so much for listening today. If you have any questions, please feel free to reach out. Here's my list of co-authors in this work, and thank you.
Great. Thanks so much for the presentation. That was wonderful demonstration of the two different matching techniques between the systems. So I just have a couple questions while we wait for other questions to come in from the audience. Please feel free to put them in the chat or Q&A from everyone who's watching at home. What was your experience did you get a chance to look at the different demographic matching differences between the two systems? Were there ones of certain demographics that fell out in one environment but not in the other?
Yeah, that's a great question. Graham Crawbuck, he was the one that had conducted these analyses. He didn't have much time to really dive into some of the differences between, the records that matched in via MPI versus our current software within production. But, for the most part, we do know that some of the records that matched only in production that MPI wasn't able to match were likely due to, in some part, missing address and phone information. Because address and phone, in addition to first name, last name, and date of birth, are core variables that MPI leverages in its matching algorithm. So we suspected that there are some differences there. And I'd say that would probably be the main differences in demographic information and how each of the two methods function. Because with the exact matching in our current software in production, it's an exact match on just first name, last name, and date of birth, or social security. So there are just fewer data elements needed in order to identify a match in our current non-MPI software. Great.
And how much manual time has been required in both systems? Is that is it difference in a lot of the lift from individuals working with the both matching systems?
Oh, that's a great question. That is to be determined because we haven't gone live with our MPI ELR solution quite yet. So I think over time we'll be able to see more of that manual burden reduced. Hopefully, right now there hasn't been a significant change in part of the MPI solution we've been able to implement so far with we call it roster imports, the data that we import via CSV that are currently flowing through MPI. One of the reasons being that with our COVID lab data, which take up a large volume of our surveillance system, we get data through both ELR and data also manually faxed to us. So there's some duplicate reporting that we're seeing on our end. So, even though some of those data are going through the MPI system, some of them are still going through our current software, which ends up hitting our workflows for manual review. So we suspect that once the ELR data are also flowing through MPI, we'll start seeing more of a reduction in manual work for deduplication.
Great. And I don't see any audience questions yet, but I'll ask one more before we switch to the next presentation. But please feel free if audience members do have questions to plug them in, and we can always get them at the end. So one other question is, as you're thinking forward to other data that you might like to link or integrate, what are the pros and cons of this proprietary system in thinking about bringing other data systems in versus how you were matching previously?
That is another great question. Obviously the pros being that as we are able to incorporate other data sources from other agencies within our health and human services coalition, the more data that are available for linking and helpfully helping bridge gaps among different records among each of the different systems, the better. We've got Verato's proprietary data system that has quite a bit of demographic information, but if it's if it can be used in conjunction with other data sources, that will allow us to say within WDRS, we have person A and person B, a data source from our healthcare authority or Medicaid that is able to link person A and B within WDRS, all the better. In terms of potential drawbacks, I think in general, one thing that comes to mind is as you're starting to coordinate with other data systems, other programs, kind of keeping in mind all of the confidentiality and security concerns, making sure that only people who should be seeing certain data are able to access it is one thing that we're really going to have to consider. And we're kind of in the midst of that now, because as Graham had mentioned, right now, WDRS and our healthcare authority are the two agencies that are part of MPI right now. But as it expands, we'll definitely something to consider.
That is interesting consideration. And we did have one audience question come in, and we'll end on this question for you. So for the MPI, what are the match thresholds you are using to know that a person is either the same or not?
Yes, that is another great question, because this was my first time kind of working with a third-party vendor with this type of information that was proprietary. And so, in addition to their person database, their matching algorithms are also proprietary. So we know some information about the data elements that are used in the matching. That's something that we're able to configure. And we know that things like first name, last name, date of birth, and address are what they call core variables that are weighted more heavily than things like phone number and gender or sex. And so we unfortunately don't have a good idea of confidence level. We were able to set a threshold score at which we could say that something is likely a match and could be automatically merged with our system. That was based on kind of prior experience and other clients that they've worked with, and we went a little more conservative in setting that threshold score. Other than that, in testing, what we've noticed is if we've, for the most part, have a record coming in that has an exact first name, last name, date of birth, and address to an existing record in WDRS or in our surveillance system, then for the most part, those would come through as identified matches.
Great. So we have one more question, but I think we'll hold it to the end because of time. Oh, we do have time for another question. All right, this one will be the last one. So the question came through, do you run into any issues with bad data getting into the system? And have you had to deal with backing out any matches that might have occurred as a result?
Yes, one of the big problems with deduplication in general is what happens, if you get a bad merge and you have to detangle and unmerge person records or case records. We haven't so far run into any issues with our current MPI implementation. From my experience, when we've had records get matched and we find out after the fact that they have to be untangled because two people weren't actually the same person. A lot of times those were a result of a manual review and deduplication rather than our exact matching. And like I had mentioned, we haven't seen anything with our MPI roster implementation that has caused any concerns. Before we implemented the first phase of our MPI project, we did look at some data and conducted some QA as best as we could to try and find false positive matches. And luckily, we didn't see anything too concerning. One of the things that we try to do to help mitigate any bad matches was implementing what we call a never match functionality, where within our system, if we notice that there are twins that have very similar names, we can mark those records within WDRS as being never match. And what'll happen is our current and our MPI system will recognize that and then divert those records and force them to create a new record in WDRS so that it goes to someone for manual review to determine, if and when these records should be matched. So hopefully that answered your question.
Great, thank you. And if there's additional questions, we can probably get to them at the end. Thank you, Jennifer, for joining. We'll bring you back on in a moment. But next up, we're going to have Ben Daly with the Tennessee Department of Health. He's going to present on linking params and HDDS data with SAS proc SQL macro. Thank you.
Hi, I'm Ben Daly with the Tennessee Department of Health, and I'm here to talk to you about linking params and hospital discharge data with SAS. In 2005, I was involved in a similar project with the Tennessee Birth Defects Registry. This project actually began as part of a CDC grant in 2022. In Tennessee, there's about 1,500 mothers in the params file each year. However, there's no personal IDs, but the data is linked to the birth certificate file. Birth certificate file contains a lot of personal IDs, including the mother's medical record number and the child's medical record number. Hospital discharge data comes from the UB04 form and contains in Tennessee about 5 to 6 million records per year. There's patient names on the records after 2017. The overview of this process is as follows. First, join the params to birth data sets to get the personal IDs for matching, then clean up all of the sets that are going to be used, then join the params birth set to the hospital discharge set, then review and archive the results. When I began this project, I was told to start with the 2012 mothers. I decided to choose about 8 variables, and then I was kind of lost. How many sets am I going to make? What sets are they going to be? How many variables will I include? And what would be the name of these sets that I chose? I decided to list all the possible sets I could come up with, going back to college probability classes and this type of thing. And I came up with, if I chose 8 variables, there were going to be 256 possible sets. And I realized that 256 was one of these binary numbers, 2 to the 8th, which was the number of variables that I chose to use. I decided to try and make all the 256 matches with the following caveats: that there must be at least 2 variables matching in the sets that I kept, and that the matches with only low quality variables would be excluded. I was going to use a proc SQL for my joins and a descending do loop. I use 8-digit binary strings for my loop counter, set names, and condition indexing, and I use the SAS macro language to facilitate 8-digit binary string manipulation. To explain what I mean by 8-digit binary strings, consider the variables that I use: Social Security number, medical record number, date of birth, mom's name, maiden name, street, zip, and city, in that order, so that the string 101001 would mean that the Social Security number, date of birth, and the city matched, but the others did not, as indicated by the 1s and the 0s. And note that the binary string with all 1s in it is equal to 255. So using the descending loop starting at 255 will give the better matches first. Each of these 8 digits also references a condition to be met. So for example, whenever the first digit is equal to 1, that means condition 1 is true, or if the first character in the binary string is 1, then the social security numbers must be equal to each other. If the first character is 0, then just disregard and go to the next step. After all these sets were made, me and some other people reviewed the results and developed the following criteria that we decided would give us the best set of matches. Ultimately, I ended up matching 11 years of mother's data and 11 years of children's data. The results were pretty good, I think. 98% of the mothers had at least one match and 95% of the babies had at least one match. Interestingly, the average amount of matched records for the mothers was the same as that for the children. Now, recall that we surveilled the mothers for 1 3/4 years, but we just surveilled the children for 1 year. So the overall average is higher for the mothers, but the average per year of surveillance is about the same. COVID affected the overall number of hospital discharge records, and it affected the amount of records here. And there was a separate parallel project that was used to analyze 2019, 2020, or make linkages for those 2 years, and the results were very similar to the results of this project. When using these sets for analysis, you have to keep in mind that the ICD code changed in 2015 from ICD-9 to ICD-10, and this can be an issue. But the SAS macro program that's used for this can be easily modified and used for other linkage projects. And here's some other analysis that we've done or will be involved with in the future. It must be noted that the mother's matching takes a lot longer than the children's because the amount of hospital discharge data that's used, that's gone through, is much larger. And you've got to keep that in mind if you don't want to shut your computer down all day. If you want to email me to get further information on this, just be aware that my email address is john.daly, but my name is Ben Daly. Thank you.
Hi, Ben. Thank you. That was a really interesting presentation. I appreciated having to go back to high school math too to help us understand some of your processing. So one of the things that you noted during your presentation was that in 2017 names were added versus initials in the hospital data set. What was the match differences post 2017 versus pre? Did you see a big shift?
No. Prior to that year, they used initials, and the initials are basically I think the first 2 letters of the first name, and of the last name, it's the first 2 letters and the last 2 letters. So, and I'm comparing, well, that gave, I think, pretty much the similar results. The overall results were about the same, actually.
Great, that's interesting. So one of the other points that came up during the previous session was how these systems deal with twins or multiples. Did you have any interesting challenges or adjustments that you needed to make when looking at matching babies who may have been part of multiples?
No, PRAMs, this is a matching the PRAM set with the hospital discharge, and PRAMs deletes all twins. And so there might have been some twins in there. We did have a couple, I think, over the 10 years where the birth wasn't really a valid birth. It was probably a stillbirth. And so there was a PRAMS record, but there was not a birth certificate record because they go out and delete it. But that was, way outlier. Very, very rare.
Okay. I mean, that is one way to deal with it in a system, is to delete it. So that's an interesting point. I guess I didn't realize that about some of the PRAMS data. please, audience members, put your questions in the Q&A. I haven't seen any come through yet, so I still have a couple more questions for Ben. You mentioned during your presentation that you don't work with low quality matches. How did you define low quality matches as part of your analysis?
Well, I think basically what I was saying is that only low quality. And I listed, I tried to develop variables that were, I guess, high quality left to right. And so I would say if they match on social security number or name, those are high quality matches. But a low quality match would be something like the zip code or the name of the street. And that's, those right there are, that's just basically a gut feeling. I have and I think it's something that most of us would agree with, is that it's very rare that two different people would have the same social security number, but very likely that maybe two people might live on the same street, have the same street name. So, there's no technical analysis behind that. It's just kind of a gut feeling. And then what we did look through and there was some back and forth on this, is like, when you do a process like this, there's a tendency to want to get as many matches as possible. But when you do that, you end up with some matches that are really questionable about, that's probably not the same person. And I've done this for a while, and I know that that's there. And so, there's this back and forth. Well, do this and we'll get more matches. And it's like, well, I'm going to argue against that because this and this. So that's kind of a touchy-feely thing. In my previous job, we actually sent nurses out and went to the records, and they did like a random sample of the charts in the hospitals and everything, and that was one of the things we looked at. Are the people matching right? And then are the diagnosis matching what was in the record? And the people, what I did before was there were a few small percentage that I overmatched, and they shouldn't have been matches. And so I want to temper myself against trying to be too overzealous and cranking that number up as high as I can.
Well, and it was nice to see you give the examples too of how you try to validate the matching results. So I think that was really helpful to see. I haven't seen any other audience questions yet. Oh wait, we just had one come in. What is the QC process to check if the matching is of high quality?
Well, basically, at the end of the, I guess at the end of when all the matches are made, I'll go back through, especially early on when I'm writing the program, I'll go through there and look for, definitely I'll look for the ones that don't match. And then I'll look for the ones that only match on what I call those bad variables. And that's why we excluded those. And it's once again, that right there is a subjective, let's call it that. It's a subjective decision that's made. And I would say probably, it looks like I didn't match 2% of the mothers. And I would say it's probably less than that on the other end that the matches are bad. We had a pretty high, I would think, we probably threw out some matches that, threw out more matches than we should have not kept, I guess. I kind of get confused there.
Great. Well, Ben, thank you so much for sharing your presentation, and we'll bring you back on at the end with the full panel of presenters today. So we're going to shift to the final presentation, which is Deja Kemp and Amy Hahn-Nelson from the Actionable Intelligence for Social Policy at the University of Pennsylvania, who are presenting Yes, No, Maybe, Legal and Ethical Considerations for Informed Consent and Data Sharing and Integration. See you back in a minute.
Hi, everyone. I'm Amy Hahn Nelson with AISP. I am joined by my colleague, Deja Kemp.
Hello.
And we are here to talk to you about ethical considerations, legal and ethical considerations around informed consent when it comes to data sharing and integration. Here at AISP, our role is to help state and local governments collaborate and responsibly use data to improve lives. What this means is that we draw upon our network of sites across the United States that we work alongside with and learn from to kind of catalog and understand best practices and current practices in this work. And so everything you're seeing here today comes from our network and from work in the field.
Perfect. So again, we're very excited to share this new resource. Our consent brief outlines the role of consent within major federal laws governing the sharing of administrative data, and it examines important ethical implications of consent, particularly in cases where the law is silent or unclear. And finally, this brief delineates the foundational role of strong governance and consent frameworks in ensuring ethical data use and offers some technical alternatives to consent that might be appropriate for certain data uses. So our report begins by discussing the legal safeguards for data sharing. Whether consent is required is going to be informed by legal authority, and consent is going to largely depend on the type of data in use. We have identified what we view as the 5 bases of a legal authority for integrating data and acquiring consent, all of which are going to be informed by the access of data, open, restricted, and unavailable. And regarding consent, most of that is going to fall within this restricted data, unavailable data area. Data sharing and integration are guided by an array of federal and state laws. It is important to note this graphic is not exhaustive, but this brief focuses on consent within the HIPAA and FERPA context. And the key takeaway is that there is no uniform definition of consent in the United States. So we begin by talking about what is consent, and a great way to start that is to talk about what we're not talking about. So in this brief, we are not talking about issues that commonly come up, like consent for medical treatment or consent to participate in a study. What we are talking about is specifically consent to share data that contains personal identifiers, and we hone in on issues when consent is optional or where the law is unclear. So when is consent required? So the general rule under both HIPAA and FERPA is that personally identifiable data can't be shared unless you have consent or unless it's laid out in a specific purpose or in an exception in a statute. So when is consent not required? So consent is not required under both HIPAA and FERPA for de-identified or aggregate data, so we're data that does not have personal identifiers. And in the brief, we highlight the main exceptions under both of these statutes. So under FERPA, the 3 main exceptions we highlight that are particular to data integration are the school official exception, the studies exception, and the audit and evaluation exceptions. And then under HIPAA, the main exceptions that we lay out are TPO, so for treatment payment and operations, the public health activities exception, the health oversight exception, the research exception, and the serious threat to health or safety. And you probably saw that come up in the COVID because that was an exception that was used frequently as as an emergency health or safety to be able to share data. So how do you get consent? So under HIPAA, there are 2 types of permissions. There is an informal permission called consent. And in that case, HIPAA permits but does not require a covered entity to voluntarily obtain patient consent for treatment, payment, and healthcare operations. And entities that elect to get consent for those 3 scenarios have complete discretion to design a process that best suits their needs. In contrast, authorization is a formal type of permission required by HIPAA that pertains to disclosures of protected health information, not otherwise allowed by the rule. So an authorization is a detailed document that gives covered entities permission to use protected health information for specific scenarios. And in this next slide, we talk about the specific elements required with a written authorization under HIPAA, namely that you need to describe the PHI that's to be used. You need to identify who that disclosure is going to be made to. You have to outline the purpose and need to give a description of the records. FERPA's requirements are similar. You need to state the purpose of the disclosure, describe the records that are going to be disclosed, and to identify the party to whom the disclosure is going to be made. And I'm going to turn it over to my colleague to talk about some of the practical and ethical problems that come up with consent.
Yeah, so most importantly, when you consent data, so when you put consent around data, you are automatically restricting your statistical validity and reliability. You no longer have a population, is another way to say about this. You no longer have a representative sample, as the people that opt in or out are usually fundamentally different. They have different characteristics. And if your purpose for data sharing integration is case management, then this is fine. Statistical validity doesn't matter. If you're using data for case management and for purposes to provide services, you don't need a representative sample. However, if your purpose is analytics and policy analysis, and consent is not required, then requiring it really prevents the use of these data for analytics, research, and evaluation. So we strongly encourage putting consent around it when you need to, but also, putting consent doesn't always mean that it's the better choice. You are preventing validity in some ways. Another thing is consent management is very, it is possible technically, but it is quite challenging. So that's another piece to keep in mind. The next issue are just issues, very related to the Belmont Report of 1979, which all IRB is subject to. Ethical problems of consent can cause erasure. Surveillance is an issue. When you apply consent to something, that could mean that you are being coercive in your activities, exerting undue influence. There are also issues around comprehension of consents. They're often written in legalese. So just because putting consent around something doesn't mean it is the ethical choice. Lastly, we want to specifically call out the implications around racial equity and consent. There are significant harms that have occurred with data. And so where there is a challenge or when there are considerations of racial equity or inequity, we highly encourage you to think carefully around consent, not only what is legal, but here really consider the ethical implications. So what might ethical consent look like? The main thing is just to think through this work carefully. Here's a 4-question framework that we provide in the report that we find really helpful. This next slide has more details around these questions, what they look like, what we're talking about, some context. And this provides and I'm going to turn it over to Deja to provide a consent framework.
Yes, thanks, Amy. So this is the consent framework that we recommend in the report, and it's modeled after the common rule. The biggest theme is giving agency to the person whose data is to be shared. So we recommend 6 elements that you see here, namely that consent not be passive or implied, that it needs to be willingly given, it needs to be understandable so that someone can read it and not fill it with legalese. The person giving the consent needs to know that they can revoke it at any time, that it's not conditioned on a benefit, so you're not going to lose a benefit if you decide not to give consent. And then finally, no exculpatory language. So in other words, you're not waiving or releasing your legal rights or saying that I won't sue you if or you can't sue us if your data is released. So we think that this is a good framework, a good starting place for considering ethical consent. And then I'm going to
yeah, and lastly, we just want to point out there are alternatives here. The next slide shows a couple different methods of technical approaches. There's much more information about this in the report, and we encourage you to check it out there.
Okay. Thank you so much for joining us. We have our contact information listed here. We also have hyperlinked the brief, and we also encourage you to sign up for our newsletter to get more information. Thank you.
Thank you.
Thank you, Amy and Deja. I really appreciated the framework at the end, highlighting the considerations for consent and really setting up those questions and criteria to walk through. One of the things that, I was thinking about throughout your presentation was, when we talk a lot now, I mean, this whole session is about linking data, and most of this is being presented by state entities. When they're looking to start a data linkage project, what are some of the first questions they really should be thinking about as it comes to consent? Where to start?
Deja, you want me to start?
Yeah, I'll let you take that one.
Okay. So, well, I'm going to punt it to you in a second. You'll see. So, yeah, I mean, the first place to start is like, what do you need linkage for? Right. So, the example from Tennessee is a very good use case of like a very specific bound need for linkage. And then, our first presenters around like a master person index, same thing. It really depends what you need it for on how you are conducting your linkage. So that's number one, is like, let the use drive what you're doing. And that's usually our answer to everything. Don't do it just because you can. Think about what you really need from it. And then the second thing is, what can you link, right? So there are real restrictions around how data can be used and for what purposes. So some of these restrictions are federal. Some of them are state. So I'm going to punt it to Deja to give specifics.
Yeah. So I think identifying like legal authority. So to Amy's point, figuring out why you, what you want to share, why you want to share, and what the law says. Like sometimes the law is clear. You have to have consent for certain purposes. Other times it might be optional. And so I think it's identifying the purpose, seeing what the law has to say, and also trying to figure out like, one thing we stress is data minimization, only asking for what you need. Is there a way to get the answers you need without identifiers? Can you de-identify? Can you get the same answers from aggregate data so that these laws aren't implicated at all? And then finally, can you rely on an exception before you have to go out and get consent?
Yeah, and it was really helpful at the beginning of your presentation where you went through some of the exceptions, and there was actually more than I anticipated. And one of them was around aggregate data and where you were able to have the data be able to use it in that way. And I guess what considerations when data sources are being combined, would you be able to put further exceptions in place to consent if the data is in aggregate? What does that look like, and what are the standards for aggregation?
So they're going to be different based on the law. So for example, FERPA is a bit more stringent than HIPAA. The biggest thing is it able, with aggregate data, you just need to make sure that it's not linkable, that you can't, there's no risk of re-identification. And then also too, like, is it truly, because sometimes when you aggregate things out, there's a risk of things being identified. So for example, if a school district said 100% of African-American males are not on reading level, even though that's aggregate, we can identify. At that point, it's re-identifiable. So just the key thing is looking to see what the standards are under the law. And the biggest takeaway is like that you should not be able to re-identify individuals with aggregate data.
Thank you. And as you mentioned, there's different legal authority, and as we embark on a variety of data linkage projects that try to bring in data sets that are under different legal authority, I can see that could get pretty complex. So one of the projects highlighted in the plenary session was, I think, talking about, bringing in data from education and health. I guess, which one do you see as more stringent?
So I'm going to say, I think a lot of people would agree that education data is a little bit harder. So FERPA was promulgated in 1974 before the internet.
And so when it was, when the legislation was created, I don't think they contemplated that we would be using data in the same way. Whereas HIPAA, there's a lot more exceptions. I think people recognize, oh, it is helpful to be able to do research. It is helpful to be able to carry out our public health activities in the same way that you don't have with, again, a statute that was created before the internet. But I don't think they contemplated the ways that education data can be used to serve the whole student. So I would say legally, I think that education data is more stringent. I do know that there is a push for revising some of the rules, getting new guidance to kind of be able to really address the reality that these systems are helpful. And so hopefully in the future, it won't be as, I think, onerous as it is now, but I definitely think, at least from a legal perspective, it's a bit harder to integrate education data just because they don't have the same number of exceptions that law like HIPAA has.
That's really helpful note as various groups look at these data integration projects. So we have one question that's specifically for the two of you, and then I'll bring back everyone for the last few minutes of the session. So what special restrictions would you recommend for those seeking use of APCDs to study small populations undergoing, for example, gender reassignment procedures where the total population of the study target might only be a few thousand at the state level?
Yeah, so our answer to all questions is data governance. So like when in doubt, it should not be one person, it shouldn't be two people, it should be a group of people who are nuanced users, who understand implications, who understand what happens if we do nothing with that data, right? Complete erasure of a really vulnerable population in our communities. But what happens if, there are significant privacy risks there for redisclosure? So our work nationally is always to, number one is set up data governance structures. Number two is, co-create legal frameworks, and those should be done together. So if you have a way to legally share these data, then you should have a way to, you should have a set process to make decisions on access and use. So I would draw upon those. For really niche topic areas like that, I would even say to bring in like subject matter experts, people with lived experience. I mean, these are really nuanced privacy considerations. And it just is going to be really important to bring in a variety of voices.
Great. Thank you so much, Amy and Deja. Like I said, I'm excited to pull down your report and read it right after the session. I'm going to welcome everyone back. I know we have only a few moments left to see the full group. Thank you so much for today's presentations. There's one last question. I think somebody may have snuck it in earlier, but just being really curious, how does your work get funded? Do you want to start? Who would like to start, I guess?
We can start. We're an open book on this. We have a lot of funding sources, everything from federal to technical assistance contracts, cohort-based TA that is largely philanthropically funded, and then, federal, state, to pretty much everything.
Great. Thank you. Jennifer?
Hi, that's a great question. I actually don't know what the funding sources for our MPI project is. I just sent a quick ping to my team to see if they knew, so I might be able to respond before the session's over. But yeah. So maybe if you want to loop back to me, it sounds like someone's responding. So thank you.
Great. Ben?
My work was done, I was funded under a CDC grant. The databases are hospital discharge is the state, I believe, and PRAMS is the, I think it's CDC or a federal grant.
Wonderful. All right, last chance, Jennifer. Did you get it on the spot?
I wasn't our team. My immediate team didn't know. Apologies.
That's okay. Well, thanks everyone so much. This time went by so quickly, and I really appreciate all your presentations and sharing your knowledge with the NATO group. Thank you.
Bye.